Hello and thank you for joining in on today's training. Heart & Solutions is a proud provider of CE eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
So like we said, we're going to go over some child sexual trauma understanding behaviors and treatments. Mary Kate and myself are both therapists at Heart & Solutions here in Davenport. I'm the clinical director. I've been here for about 2 years and Mary Kate's been here for about a year. Objectives for today, we just have 2 of them. We're hoping everyone gains an understanding of behaviors displayed by children who have been sexually abused and gain an understanding of treatment approaches for children who have been sexually abused. Our outline for today, we are going to go through a case study, talk about definitions, prevalence, risk factors, and the impact, behaviors, mental health diagnoses, treatment approaches, some self-care tips, and then at the end, we will have time for questions or discussion that we might want to go through.
All right, so Emma and I wanted to include a case study just because from our understanding, it sounds like you guys tend to step into the case more towards that court side of things, towards the end of a case. Just wanted to run through though, kind of not typical, but just kind of what things look like from start to finish. So I'm gonna read through this case study and then at the end, I'm going to ask for some thoughts, some feedback. You guys knew some of these things, if you knew this was kind of how things went, and any questions. So Anna is a 9-year-old girl and is currently in 3rd grade. She lives with her mother, Miss B, and her 14-year-old brother. At a recent visit to the pediatrician for a well child appointment, Anna refused to remove her clothes and became extremely agitated when the physician started to examine her. She started crying and disclosed that her stepfather had been hurting her. Upon further inquiry, she said that he had been forcing her to engage in sex stuff. Miss B was visibly shaken and distressed by the disclosure, stating that she had no idea that this had happened. She did acknowledge that she and her husband had been experiencing marital problems, which resulted in his moving out of the home temporarily about 6 months ago, but she was still seeing him and he was still in the house frequently. Miss B did not understand how this could have happened, as she rarely left her children home alone with her husband. Furthermore, she said that she and Anna have a very close relationship and that Anna would have shared this if it had occurred. Since Anna was extremely upset after her disclosure and Miss B was having difficulty believing the allegations, the pediatrician recommended a referral to the local child advocacy center for a forensic interview and medical examination. While Miss B was still in the office, the pediatrician contacted the CAC to schedule the evaluation and allow Miss B to speak directly with the CAC to provide any required information. The pediatrician then explained to Miss B that a report would have to be made immediately to the local Child Protection Services office. Miss B became increasingly hostile and angrily stated that she did not understand why Anna had to be seen at the CAC and a report needed to be made, as this really couldn't have happened. Because of her obligation as a mandated reporter, the pediatrician explained that the report was required and that the best plan would be for them to make the telephone call together. As the alleged perpetrator was a primary caregiver, the child's stepfather, the pediatrician made the report to the local CPS office. The CPS intake worker stated that a worker would be at their home that day to interview Anna and her mother and to establish a safety plan. Anna was scheduled for the CAC evaluation the following week, and the CPS worker said that she would also plan to attend the appointment as a way to reduce the number of times that Anna had to undergo in-depth interviews. The CPS worker indicated that she needed to contact law enforcement and asked Miss B for specific information about her husband, which Miss B refused to provide. The worker informed her that this would entail the police coming directly to her home to question her husband, to which Miss B responded, "Do what you need to, but I won't help you." Despite Miss B's anger and disbelief, she reluctantly allowed the pediatrician to conduct a cursory physical examination of Anna, but deferred a genital examination until Anna could be seen at her local CAC for a medical examination. Ms. B did attend the CAC evaluation, stating that she just wanted to get this over with so that everyone could leave her family alone. At the CAC evaluation, Anna was noted to have a normal genital examination with no signs of injury. Ms. B asked if this finally proved that the abuse never happened. The medical provider explained that the majority of children who are victims of sexual abuse do not have signs of injury, regardless of the timing of the examination. In addition to the physical examination, a forensic interview was conducted at the CAC. The purpose of a forensic interview is to determine the details of the child abuse allegations without asking leading questions or causing undue harm to the child, and to render an opinion on the credibility of the child's disclosures. During the course of the forensic interview, Anna said that her stepfather had started abusing her about a year ago, and that it happened multiple times a week while her mother, a nurse at the local hospital, was working the evening shift. Anna indicated that her stepfather would read to her in bed, and that one night he started touching her chest and rubbing her legs. He said that this would help her to sleep. Over the subsequent months, the abuse increased in severity, involving vaginal penetration and forced oral sex. Anna stated that her stepfather warned her not to tell anyone and that no one would believe her, even if she did tell. He also told her that if her mother found out, he would go to jail and Anna would have to go to foster care. Anna also said that she had nightmares, felt scared all the time, and was really scared of men. Miss B was also interviewed and continued to express her anger and disbelief. She stated that she had no idea how this could possibly have happened. She admitted to marital problems, but said that she and her husband were trying to work things out. She agreed to obtain treatment for Anna so that they could put the whole thing behind them. On the basis of the forensic interview, Anna was referred to a mental health provider housed at the CAC who could conduct a psychosocial evaluation and determine her treatment needs. Evaluation results indicated that Anna met the DSM-5 criteria for post-traumatic stress disorder, including re-experiencing symptoms like nightmares, frequent stomach aches when reminded of the abuse, avoidance of thoughts and feelings or reminders of the abuse, negative thoughts and feelings, and self-blame about what happened, loss of interest in activities, feeling alone and isolated, and trauma-related arousal, such as increased irritability, difficulty sleeping and concentrating in school. Based on these findings, the therapist recommended trauma-focused cognitive behavioral therapy. This parallel treatment model also gives the therapist the opportunity to work with caregivers such as Miss B, who are also having a difficult time believing their child's allegations. While Miss B was initially angry and disbelieving, she did want Anna to be okay, and she brought her regularly to the treatment sessions. The therapist worked closely with Miss B to address her anger and disbelief, providing extensive psychoeducation about why children do not disclose, sharing specific examples of what her husband had said to Anna, and exploring the impact this had on Mrs. B directly. After about a month, Miss B was more invested in treatment, and although she still struggled with believing all of this, she did separate from her husband. Anna evidenced some improvements, but was still experiencing significant fear and anxiety, particularly around men. She was still having difficulty sleeping and concentrating in school, and she still had frequent stomach aches when she thought about what happened. As these symptoms were impeding her treatment process, the therapist made a referral to a psychiatrist for medication assessment. Anna was started on fluoxetine, which after a titration to 30 milligrams a day significantly improved her sleep and anxiety symptoms. She continued to engage in trauma-focused CBT, and after approximately 6 months, Anna's symptoms were substantially improved. Mrs. B was able to acknowledge the sexual abuse by her husband and was contemplating filing for divorce. Anna was tapered off the fluoxetine approximately 12 months after initiating the medication, which she tolerated well. So that is, I believe, the end of the case study. Does anyone have any thoughts about this portion of how kind of these sexual abuse cases come to light and this portion of the process?
It seems like that, I would think that would be almost a, I don't want to say normal situation, but anymore it kind of is.
Yeah, it's a pretty textbook example of kind of what happens oftentimes, I guess, and it's a very good example of kind of how on our end as providers, how we end up getting kiddos to treatment. and then what happens with the kind of the medication, how the forensic interviews fit into the equation, stuff like that. Obviously, no case is textbook, but this is a pretty good timeline of how things happen.
Obviously, the child was left alone with the stepdad if she went to work. You know, it's like she's never left alone with them, but I go to work every night.
Right. We do see sometimes that parents, those are things that you don't even think about because you have to go to work. So those aren't even considerations a lot of times for parents. And I think too, this is a pretty good example of somebody who, you know, you don't want to believe the allegations initially. All right, Emma is going to dive into the definitions, prevalence, risk factors, and impact.
So just to start out with, the definition, childhood sexual abuse is generally defined as a form of child abuse that involves sexual activity. Any completed or attempted non-completed sexual act, sexual contact with, or exploitation of a child by a caregiver, including differentiating between those involving direct physical contact with or without penetration and non-contact sexual abuse as well. The World Health Organization extends the definition of childhood sexual abuse beyond that perpetrated by a caregiver. So the involvement of a child in sexual activity that he or she does not fully comprehend, is unable to give informed consent to, or for which the child is not developmentally prepared and cannot give consent, or that violates the laws or social taboos of society. Child sexual abuse is evidenced by the activity between a child and an adult or another child who by age or development is in a relationship of responsibility, trust, or power, the activity being intended to gratify or satisfy the needs of the other person. This may include, but is not limited to, the inducement, coercion of a child to engage in any unlawful sexual activity, the exploitative use of a child in prostitution or other unlawful sexual practices, or the use of children in pornography performances or materials. So prevalence and statistics is a really hard thing to report on, just because the numbers are changing. The reporting is up, down, not everyone reports. So it's really hard to say the exact statistics. This is what I was able to find though. Every 9 minutes, Child Protective Services substantiates or finds evidence for a claim of child sexual abuse every 9 minutes. Many children wait to report or never report child sexual abuse. Like I said, therefore, the numbers are likely underestimated. What I did find is about 1 in 4 girls and 1 in 13 boys in the United States experience child sexual abuse. Someone known or trusted by the child or the child's family members perpetrates 91% of child sexual abuse. Risk factors, gender, approximately 3 to 4 times greater risk for girls over boys. Race and ethnicity, minority children, especially those of African American or Latino ethnicity, appear to be at a higher risk for sexual victimization. Those in lower socioeconomic status, residing in the home of a single parent. A lot of times this could be because of that trust in others to watch your child, whether that's other family members, family friends, daycares, being in foster care, parental substance abuse or mental illness, living in a rural area, or in domestic violence, all add to the likelihood as well. The impact. Examples of physical consequences include sexually transmitted infections, physical injuries, or chronic conditions later in life, such as heart disease, obesity, and cancer. Examples of mental health consequences include depression, anxiety, and PTSD symptoms. Examples of behavioral impact include substance use or misuse, risky sexual behaviors, meaning sex with multiple partners or behaviors that could result in pregnancy or STIs, increased risk of perpetration of sexual violence, increased risk for suicide or suicide attempts. Experiencing child sexual abuse can also increase a person's risk for future victimization. For example, recent studies have found females exposed to child sexual abuse are 2 to 2 to 13 times increased risk of sexual violence victimization in adulthood. And people who have experienced child sexual abuse are at twice the risk of non-sexual intimate partner violence as well. So why doesn't every child tell? There are, several reasons, and every case is different. Perceived responsibility for the abuse is a big one. A lot of kids think that it's their fault or they deserved it. This, someone that they trusted was doing this to them and telling them it was okay. Fear of negative consequences. They think they're going to be in trouble. In that case study, the stepfather was telling her, you can't do this, you're going to be in trouble, I'll go to jail, all of that kind of stuff. Being the victim of incestuous abuse, reliance on an adult to make the report is a big one. They might tell somebody, especially if they're not using the correct body part names. They might be telling someone exactly what is happening to them, and the adult they're telling doesn't understand. Perfect example of this is, I heard this when I was working in childcare. A small child was telling her daycare teacher that her uncle was eating her cookie every night. He was eating her cookie every night, and the teacher didn't know what that meant. She thought it was just, they were having cookies together, and what she was trying to tell her was that she was being sexually abused by her uncle, and by calling her private parts her cookie, no one understood what was happening. Recanting, this is a big one. We have kids that disclose, and then when they go to their forensic interview or talked to by a DHS or whatever it is, they recant. And the number one reason recanting is that their primary non-offending caregiver doesn't believe them. Again, we could see this in the case study. Miss B was saying, there's no way this happened. He didn't do this. And children are more likely to recant the younger they are. And this could be, not fully understanding what is happening and why it's happening. And recantation is largely the result of the lack of familiar support or familial influences, not the result of false allegations. So again, back to the case study, Anna's mom not believing her was, she could have easily recanted that story saying, oh, never mind, it didn't happen, because she wanted her mom to not be mad at her. She wanted the whole situation to just be better, and end.
I think it's important too to note with recanting that kids often pick up on energy too. So even if their parents are saying, the non-offending parent is telling them that, I believe you, it's distressing for a child to see a parent in distress. And so sometimes we see that happen as well, where, parents are being very emotional about things and kids want to make it better. So they're going to say that it didn't happen.
Yeah, definitely. Some statistics here for you. Again, 23% of children recant their abuse. 46% of children recant because their mother suggested that they should. And 48% of children who recanted eventually reaffirm at least one of their statements. So we are seeing, just a little under that half that do recant, then go back and are able to disclose again, say, take back the recantation. So a little bit more about behaviors and understanding them. So some potential behaviors are maybe warning signs, nightmares, difficulty sleeping alone, sudden or increased fear of the dark, bedwetting for a child who is previously toilet trained, sadness, just being withdrawn, irritability or anger outbursts, headaches, stomach aches, and fatigue. Again, these are, symptoms of a lot of things. So it's not to say, just because a kid is having these things that they were sexually abused, but these are things that, someone who has been abused may be going through. Another big one is just children may display sexual knowledge, language, or behaviors that are inappropriate for their age, such as hyperarousal, self-pleasuring, or perpetrating on others. So just trying to understand these a little bit more. I think a lot of adults struggle with understanding why these things are happening, and extensive grooming techniques by the perpetrator. and being told that their abuse is normal, that this is just what happens. I was at a training a few months ago where we were talking a lot about child molesters and those they've perpetrated on. And there was this story that it still really sits with me. And I think about it, that there was this young girl, she was a teenager, maybe 15 or 16, the presenter said, and she was talking with her friends and she made this comment about being sexually involved with her dad. And she said, you know, when you have to do this for your dad. And all of her friends looked at her like, what are you talking about? And it wasn't until that moment that she realized that wasn't normal. And that's not what father-daughter relationships were like. Her dad had her believing that her entire life, that that was normal and that's what fathers and daughters did. So that is a huge one, especially for that long, over a long period of time, abuse is the perception that this is normal and this is just what happens. Another big one is missing the attention that they once received. So if this is after they have disclosed and it could be like recanting or wanting to see that person, wanting to see the perpetrator, asking about dad, stepdad, whoever it was that did it, and wanting to see them. They miss that attention. They got so much one-on-one attention from that person and special treatment from that person that even if they can acknowledge and understand that what happened wasn't okay, that attention was nice and they liked having that attention from someone.
I think
And another big, go ahead, Mary Kate.
I was just going to say, I think this missing attention is one of the most confusing and distressing things for parents and adults in the situation. I know I've had parents come in and say, you know, kiddo is asking me to do the things now that non-offending or that offending parent had done to them. And at the end of, you know, talking through things with her kiddo, she was able to understand that it was the attention. It's that one-on-one time that she misses, not the actual abuse. But kiddo could only communicate that they missed that abuse.
Yeah, and then another big one too is just bodily reactions. You know, it comes down to it feels good, and that, you know, depending on how long it was going on, they got used to it. They got used to that feeling, and kind of what Mary Kate was just saying, like wanting that attention back and, you know, the attention that they used to always get from that person in that way. The length of abuse. So typically, the longer the abuse, the longer the recovery. Many times, the longer someone is abused, the longer it takes for them to, quote, unlearn their trauma responses and behaviors. Those who have been abused once are oftentimes likely to process their trauma and, quote, move on faster than those who are abused for several years. Again, every situation is different, though, and every child is going to react differently to their abuse or their traumas. It's important to realize that, you know, especially what one might see as traumatizing, someone else might not as well. And that idea of moving on quickly from a trauma, it doesn't work for everyone, and it especially doesn't work for kids. So being able to acknowledge the abuse and work through it is the biggest thing. And it's hard to say how long that's going to take for a lot of kids.
Right. So the mental health diagnoses that we tend to see in kiddos who have been victims of sexual abuse. So PTSD is a big one. Symptoms are reliving the event over and over. We often see kids do this through play as therapists. You know, we've got kids who associate police officers with bad things happening. So we see them picking out police cars for things. I had a kid who was in a car accident and we replayed the car accident and that feeling unsafe over and over for weeks. We see nightmares and sleep problems, becoming upset when something causes memories of the event, lack of positive emotions, intense ongoing fears or sadness, irritability and anger outbursts, hypervigilance, acting helpless, hopeless, or withdrawn, feeling numb, and avoidance of people and places associated with the event. So because children with PTSD or another form of trauma diagnosis often display symptoms of restlessness, irritability, difficulty staying organized, and anxiousness, they're oftentimes diagnosed with other things like ODD, which is oppositional defiant disorder, ADHD, or having anxiety. So, and then the types of therapies utilized to address symptoms of trauma and PTSD include cognitive behavioral therapy, specifically trauma-focused CBT, and play therapy, and then narrative therapy. Acute stress disorder. So this is a diagnosis that can occur that we can diagnose within the first month after a traumatic event. Symptoms of acute stress disorder are like PTSD symptoms, although they might be present for longer than a month, or they must be present for longer than a month. This is also another one that we diagnose quite frequently. So unspecified or other specified trauma or stressor related disorders. Essentially, this is a disorder or a diagnosis that we give when there isn't sufficient information to make a specific diagnosis, such as acute stress disorder or PTSD. Again, has a lot of the similar symptoms as acute stress disorder or PTSD. We just don't have that full picture yet to make an accurate diagnosis. It can be used to describe symptoms that are associated with traumatic events and trauma disorders that are causing distress and impairment, but don't also meet the full criteria for the prior diagnoses. Adjustment disorders. These are one of our favorites because it is something that obviously anytime a kid goes through an adjustment, you're going to have some changes in behavior. Big thing with adjustment disorders is that they're temporary. So we get reminders from our agency every 6 months that, oops, we have an adjustment disorder. Time to see if, is it a true adjustment disorder? Is something else going on? Or has kiddo kind of worked through whatever they're trying to adjust to and it's time to discharge? So adjustment disorders are like stress-related conditions, experiencing more stress than would normally be expected in response to a stressful or unexpected event, and causes significant problems in relationships at work or at school. Things like genetics, life experience, and temperament may increase the likelihood of developing an adjustment disorder. This is something that we often use for things like divorces, moving, going into foster care. Most of the time we end up changing this diagnosis later, depending on how things progress in therapy, if we see that there's more anxiety related or depression related symptoms. But when a kiddo comes in specifically stating that there is something big that happened in their life that just changed, this is the diagnosis that we would use. Anxiety. So anxiety symptoms include trouble sleeping, complaining about stomach aches or other physical problems, so psychosomatic symptoms, avoiding certain situations, being clingy around parents or caregivers, having trouble concentrating in class, being fidgety, tantrums and other behavioral concerns, and being very self-conscious. As we go through those symptoms, you might notice that they do often correlate and overlap with some other diagnoses as well. So that's something that we have to be very conscious of when diagnosing. Types of anxiety. So we've got generalized anxiety disorder, separation anxiety, which we see a lot of times in kids, social anxiety disorder, selective mutism, panic disorder, and then a specific phobia. The types of therapies that are used to address these symptoms include CBT, dialectical behavioral therapy, exposure therapy, play therapy, and then narrative therapy.
I wanted to interject there for a second about that specific phobia. Got an example of a kid that I used to see a while back. She was sexually abused in one of the closets in her home. And I think the closet is a sometimes scary place for kids in general. However, she, after that incident, was not able to even go grab a coat out of like the front hall closet or anything to do with closets at all, really. She wouldn't want to walk close to them, wouldn't want to get anything from them. And that's a good example of that specific phobia that she, was so worried about closets in general, not just in her house, just anywhere.
So depression is also commonly diagnosed after in children with child sexual abuse. Those symptoms, crankiness or anger, continuous feelings of sadness and hopelessness, social withdrawal, being more sensitive to rejection, changes in appetite. We frequently see it usually decrease in appetite, but it can be an increase as well. Changes in sleep. Again, we often see that it's the need for excessive sleep and some isolation, but it can be sleeplessness as well. Verbal outbursts or crying, trouble concentrating, fatigue and low energy. Again, those psychosomatic complaints that don't react or respond to physical or medical treatment. Trouble during events and activities at home or with friends, in school, or during extracurricular activities and with other hobbies or interests. We often see that with depression, kids' passions tend to just kind of dry up and they're just happy to just sit at home by themselves in the quiet. Feelings of worthlessness or guilt, impaired thinking or concentration, and then thoughts of death or suicide. So the therapies that we use to address these symptoms include CBT, DBT, play therapy, and then narrative therapy again.
Okay, so I'm going to dive into a little bit about the therapy approaches and treatments. A big reason that we wanted you guys to have a little bit more information about these different diagnoses was as we work about the treatments, but then also, if the families you're working with and these children have different diagnoses and parents bring them up to you or ask questions, just so you have a little bit of an understanding about what we're looking for and what we see with kids and why we choose to make the diagnoses that we do. So approaches and treatments. So a big therapy modality that is used across the board by a lot of therapists for a lot of different reasons is cognitive behavioral therapy, or CBT. It's a common, like I said, type of talk therapy that assists the client in identifying, understanding, and reframing negative, distorted, or unhelpful thought or behavior patterns. It's also used, like I said, to use for a wide range of issues. So there's some main steps in CBT: identifying troubling situation or conditions in your life. This would be pretty easy given being sexually abused, becoming aware of your thoughts, emotions, or beliefs about this problem. So that would be identifying those negative thoughts that they may have, that this is my fault, that this happened because I did this or because I didn't do this. So the next step would be identifying why that is negative and why that's not true, and then assisting in reshaping those and reframing them to help them understand that this was not their fault, that this didn't happen to them for this reason or that reason. So like I said, that is a pretty big one that is used across the board.
I had a beautiful example of this earlier this week. I had a kiddo that came in saying that her parents' divorce was her problem, had been sexually abused by dad, and has been telling herself that she is the reason that her parents got divorced. And so we looked into identifying just why she thinks that, why she feels that, identifying that it's inaccurate and that adults are responsible for their own actions and their own consequences, and came out of the session with a newfound feeling of like, I didn't do anything wrong. I did not cause this. I'm a kid. I don't have to be responsible for somebody else's actions.
Trauma-focused CBT is more so on focusing on trauma, obviously, and using this in the aspect of being trauma-informed. So it addresses specific emotional and mental health needs of children, adolescents, adult survivors, and families who are struggling to overcome the effects of trauma. That family aspect is a big one for TFCBT. So because the client is usually a child, it often brings in the non-offending parents or other caregivers into treatment. So that is back again to the case study where the therapist was also working with mom and helping her to understand, what happened and why this was happening. So the cognitive behavioral techniques are used to help modify distorted and unhelpful thinking, like we were saying. And then family therapy approach looks at the interactions among family members and other family dynamics that could be contributing to the problem, and assists in teaching new parenting, stress management, or communication skills that can assist the family as a whole. And I think that goes back to what Mary Kate was saying earlier about kids really feeding off of the emotions and the stress of their parent. This is not at all to say that parents shouldn't be emotional or stressed in these situations. This is obviously very, very hard for the parents as well. and getting into that TFCBT can help them understand their own emotions and work to address them on their own so their kids aren't feeding off of them quite as much. DBT is a type of cognitive behavioral therapy. The main goals are to teach people how to live in the moment, develop positive ways to cope with stress, regulate their emotions, and improve their relationships. So I personally see this used more with older kids or adults. It can definitely be used for younger kids. It kind of is more where they are at developmentally rather than their age, if they are able to kind of follow these components, which is the core mindfulness, distress tolerance, interpersonal effectiveness, and emotion regulation. A big thing in this one too is helping kids to identify their emotions and identify that like their instinct. What behavior is your instinct when you're feeling this way? So the one that I always use for kids is, when you're feeling sad, your instinct is to go curl up in bed and cover up and take a nap or whatever it might be. What's the opposite of that? The big thing is like doing the opposite to emotion. So when you're feeling this emotion, this is what you would normally do. And let's go do the opposite of that. So if you want to go curl up in bed, instead, let's go on a walk. Let's go play outside for a little bit, whatever it is they can do. And that helps with regulating their emotions and not letting the sadness or the anger or whatever it is completely take over, acknowledging it and it's there and that's 100% okay. You get to feel all of your feelings. It's just what we do with them and we want to be able to be productive with them. Play therapy. Play therapy is a big one for younger kids. I'm going to discuss play therapy and play-based therapy, just both of them as one. So play therapy is defined as the systematic use of model to establish an interpersonal process wherein trained play therapists use therapeutic powers of play to help clients prevent or resolve psychosocial difficulties and achieve optimal growth and development. Play therapy essentially allows the child to tell their story, express their thoughts, have their emotions validated, etc., through their natural language as a child, which is play. So licensed mental health professionals utilize play therapy and play-based therapy to help their clients to better express themselves and resolve their problems. Play therapy requires a safe relationship between the therapist and a client, which all therapy does. But this allows the child to best express both their needs and concerns. So it's typically utilized for the following concerns: behavioral problems such as anger management, grief and loss, divorce and abandonment, and crisis and trauma. Behavioral disorders such as anxiety, depression, attention deficit, hyperactivity, autism, and pervasive developmental, academic, or social development, physical and learning disabilities, and conduct disorders. Another big one that involves the whole family is parent-child interaction therapy, PCIT. It is an evidence-based treatment for young children with behavioral problems. PCIT is conducted through coaching sessions during which the parent and child are in a playroom while the therapist is in an observation room watching these interactions between the child and their parent through a one-way mirror or a live video feed. The parent is wearing an ear device through which the therapist provides coaching skills, and the parent is learning in the moment to manage the child's behavior. PCIT contains 2 phases. The first phase assists in establishing a warm and healthy relationship between the child and parent, while the second phase allows the parent to address behaviors in a calm and consistent manner. PCIT can be done in conjunction with other therapies to assist the potential behaviors that may arise from abuse. So a child could be engaged in individual therapy, utilizing CBT, DBT, play therapy, whatever it is, and be engaged in PCIT with their parent to address the behaviors that could pop up because of the abuse. EMDR is another big one. Again, this is more focused on older kids or adults. I have seen it done with children though as well. So I just wanted to make sure we talk a little bit about it just so you guys have a little bit of knowledge. So this enables people to heal from symptoms and emotional distress that are a result of disturbing life experiences. It has about 8 different phases. So the first phase is history taking. So just understanding the history and the trauma and what the focus is to address. So then preparing the client would be phase 2. Phase 3 is assessing the target memory. So what is that specific memory that they are looking to discuss and then work through? And phases 4 through 7, processing the memory to adaptive resolution. So these phases will be repeated as needed for the different specific target memories. And then the last one is evaluating treatment results. So was it successful? Do we need to revisit something like that? So differences in approaches. I know I just threw a lot of different approaches at you. So it's just really important to remember there's no one right way to treat symptoms or behaviors. Every client reacts differently to approaches. Sometimes you've got kids in here in, therapy office that just love to talk and they're good just talking about what happened. Some kids want to draw, some kids want to play. So it's important on the therapist side of it to follow your client's lead and let them kind of lead you for what they're ready for, how they want to do it. And it's also important to remember clients aren't tied to one approach. Many therapists utilize many different modalities in treatment. So one session with a client, your focus could be CBT, and then the next one it's DBT, or the next one we do play-based therapy. So it's not we sit down with a client and this is what the modality we're going to use with them for the entirety of their services. And like I briefly mentioned earlier, some services can be utilized in conjunction with one another. So clients can be engaged in different individual therapies and then also be an EMDR to discuss specific abuse or in that PCIT with their parents. It's just always best practice to talk to the providers and make sure everyone's on the same page just to ensure that continuity of care through multiple providers. It's really important to remember some of the previously mentioned approaches require specific trainings and certifications. So not every therapist can just sit down and do EMDR. That is a really big one that requires an extensive amount of training. And Georgie, and I see your question, the phases. I honestly do not know how long the phases last for EMDR. I think that's what you're asking about. I'm guessing it depends on the client and how, what their needs are. But that is not something that I am certified in. So I don't have all of the knowledge on that. Or you can say something, Mary Kate?
I do know that you can bounce back and forth between the different phases as well. That I think all of the phases are different depending on kind of what happened, and it's individualized. But then I do know that you can go back and forth and weave your way between different phases depending on what's needed.
Yeah, perfect. And then play therapy is another big one that you have to be a registered play therapist. Any therapist can do play-based therapy. That's something that Mary Kate and I both utilize a lot with our younger children. It's important to remember though that to have an actual play therapist, you have to go through extensive supervision and training and to be a registered play therapist. Super quick before I dive into this slide, Carol, which therapies are used with autistic children? It honestly would depend on how functioning they are. If they're able to communicate 100%, some sort of talk therapy could be utilized, or play therapy. I think when we talk about play therapy and play-based therapy, a lot of times we picture, 5, 6 and under. That's not always the case. I have had 12, 13-year-olds come in my office and want to play with the toys, and they engage very well in playing with the toys. So it depends on the functioning level of the child, but it definitely could be any of these therapies if they were appropriate.
think comprehension and language skills are very important, which is something that we would assess in the intake and then kind of continue to assess as therapy would go along, kind of what would best fit for the child's developmental and comprehension levels.
Yeah, for sure. And to, we can always, if we do that intake and we are seeing like, that level is not there for them that would be needed to engage in talk therapy and even play therapy. Play therapy does require a certain level of comprehension. We refer out to speech therapy, to OT, and help those kids get those resources so they can be at that level that we need them to be. Perfect example, I had a kid not that long ago. He was younger. He was not developmentally where he needed to be to get and really anything out of play-based therapy, other than coming into my office and getting to play with toys for about 40 minutes. So that was a conversation I had to have with his caregiver and just, ask her, engage him in speech therapy and OT and get him to that level, and then give me a call, like, let's get this going again. So that is something that we do frequently and when needed. Long-term versus short-term therapy. So the length of services depends greatly on the child, the therapist, and the parent, and just the severity or length of the abuse, the child's trauma response, interactions between the therapist, child, and parent, the child's response to treatment interventions, and the child's ability to engage. This is a huge one for children of all ages, really. I personally probably see it more in teenagers, but just that ability to trust and engage with the therapist, and being able to get what is needed out of services. And another big thing to remember too is just because you don't click with the therapist that you got and you're not making progress doesn't mean you wouldn't make progress with someone else. It's not like a one size fits all in the therapy realm. You really have to be able to trust and build that relationship with your therapist. So if any of your families or people that you work with are talking about how they dread going to therapy or don't really feel like they have a connection with their therapist, encourage them to talk to their therapist about it. I think a lot of times people are worried they're going to hurt our feelings, and that's just not the case. I would rather know and address any issues there might be with them if that's something we can fix. Like, I've 100% want to do that. And sometimes it's not something we can fix. Sometimes it's just a personality thing, and that's okay. And I want them to get the most out of their services, even if it's not with me. So being able to have those conversations is so important. So last thing there, different modalities include a different number of phases, required sessions, etc. And every client and therapist are different. So some of those modalities might go a little quicker than others. Some takes, like that PCIT, they require those phases, that initial phase to build that relationship. And sometimes that'll go really quick because that relationship's already there. Sometimes it'll take a long time because there's a lot of trust that needs to be built between the child and parent. So all in all, it just really depends on the therapist and the client.
Another note for just therapy interventions with kids who have been sexually abused, it's also very common to successfully discharge from therapy in one developmental state. They've completely processed, the trauma that's happened with where they're at developmentally. We see this a lot with younger kids when they start going through puberty. We've got some more stuff there that we have to kind of dive in and deal with and process, that their little brains didn't even think were a thing yet. So it's not uncommon for kids to come in and out of therapy and successfully discharge from therapy a couple different times based on different things that are happening in their life. It's not a failure if you have to come back to therapy. Some parents I know think, oh, great, like we've dealt with this. This is over and done with, but different things that happen throughout life are going to bring that back up. And so, yep, you might successfully discharge from therapy as a kiddo and have to come back in and readdress some of those things that now developmentally kids are kind of starting to understand about the abuse and the trauma that they experienced when they were younger.
Yeah, and not even that too, just thinking people coming back in as adults to process childhood trauma, whether that's physical or sexual or even emotional. They might have been engaged in therapy when it happened or right after it happened and processed it and were able to discharge, like Mary Kate said. But as we get older and life events happen, for significant other, for all of these things, getting married, having kids, that's a big one too, that a lot of people come back to therapy as an adult because they are having, like, they had their first child and they're just full of anxiety about that happening to their kid. So yeah, that was a great point, Mary Kate. I wish I would have added that to the presentation, but it's totally normal to come back and re-engage in services.
I would argue too that we like to see you come back. Like if things happen, like come back, please come back. Okay, so vicarious trauma and self-care tips. So vicarious trauma is the process of change resulting in empathetic engagement with trauma survivors. So anyone who engages empathetically with survivors of traumatic incidents, torture, and material relating to their trauma is potentially affected. So as CASA workers, obviously, you guys hear a lot of details of some of these pretty brutal abuse cases. So the signs and symptoms of these things: difficulty managing emotions, feeling emotionally numb or shut down, fatigue, sleepiness, and difficulty falling asleep, physical problems or complaints, aches, pains, decreased resistance to illness if you find that you're getting sick all the time. Vicarious trauma can also be called compassion fatigue or burnout. So self-care tips for any kiddo that you're working with who might need just a little bit extra, take some time for themselves, get themselves emotionally back on track. Self-care tips: writing down feelings, taking a nap, listening to music, moving, playing a game, reading books. We always love the petting an animal or snuggling a stuffed animal. We have a therapy dog that comes in on Fridays and our kiddos love to give pets and snuggles. Hugging a loved one, having a dance party, doing a craft. If the kid is old enough, making a list of things that they are thankful for. Big one too, talking about feelings with a safe adult. Sometimes that doesn't mean mom and dad, sometimes that means your CASA worker. Parents also experience vicarious trauma, burnout, and compassion fatigue, especially if they're dealing with a child who has been sexually abused. We encourage parents to schedule time to talk to other adults. A lot of times, if the offender is a parent or a caregiver of the child, that leaves the other parent by themselves doing single parent things, and that can be very stressful. So making sure that they take time to interact with other adults, engaging in mental health therapy, unplugging from technology, making space for their emotions and acknowledging feelings without judgment. Common to feel guilt, it's common to feel anger. Sometimes parents want to kind of stuff those things down and not acknowledge them, but they tend to just build up until we explode or come out in other not helpful ways. Creating a list of affirmations. I always tell my parents who have kiddos who have experienced sexual abuse that they're doing okay. You didn't miss anything, you trusted your gut, you're a good parent. Things happen. Creating a sleep routine, eating healthy foods, asking for help when needed is a big one. Spending time with friends and family, prioritizing activities that make you happy, meditating, carving out time to be alone, especially if you're a parent who the offender is another caregiver and you get left on your own to parent, making sure that we take time to be by ourselves, and then going for a walk. Finally, for workers or providers. So body awareness and deep breathing, creating a gratitude journal, engaging in educational opportunities. Things like going to trainings can empower you and renew your sense of empathy and abilities and confidence in your own abilities to help others. Utilize your support system. So that means family, friends, coworkers. If you had an emotionally draining day, have that safe person that you can talk to and just let out some of those feelings. Reading, creating a good routine for sleep hygiene. If we're sleep deprived, we tend to be crankier and have less stress tolerance. Journaling, talking to a coworker or mental health professional, practicing mindfulness or meditation, taking time to really be in the moment. taking walks, taking breaks as needed, especially, during your day. If you're at court, can be a lot, knowing that that's okay to just need a moment to walk outside, take a deep breath, regroup, and then go back and do your job. Setting goals, stretching, and then acknowledging and connecting with your emotions. I think the big thing with self-care is that it's getting a little less taboo, but it seems counterintuitive to focus on yourself and to take time for yourself. But I always use the example of on an airplane, when the oxygen masks drop, they ask you to put yours on first before you put on the child next to you's oxygen mask. And why do they do that? Because you're going to be no help if you're passed out. You can help more people. Seems counterintuitive. Your instinct is to immediately go help somebody else, but you can't help other people if you don't help yourself first. So taking time sometimes for yourself seems selfish, but it's not selfish. It helps you continue on, build that confidence, and increase your stress tolerance so that you can help more people.
Yeah, definitely. You can't pour from an empty cup. You have nothing to give if you don't take care of yourself. So as much as I think probably everyone on here wants to help as many people and families and kids as possible, we've got to take care of ourselves in order to do that. And our main goal of adding this vicarious trauma and self-care tips for you guys was so you guys would understand it and have those tips, not just for yourself, but to be able to give to the families that you work with. So that's all we've got tonight. We do have some time for questions, comments, any thoughts you guys might have or want to discuss.
So you guys that was a very good presentation. Right. So let us assume a child has a 504 plan or a child has an IEP. I realize you need releases, but would you be, or do you attend those types of meetings to give as much background as necessary to the staff who might be directly working with that child, whether it be a psychologist, school psychologist, social worker, speech pathologist, etc.?
Yeah, so like you said, big thing would be that release of information. We would have to have a release for the school or any other people who are in the school but don't actually work for the school. And like AEA is a big one that goes into the schools, but like they're not actually the school district. We do have therapists that go to IEP meetings and that kind of stuff. I personally have talked to a lot of teachers and principals and counselors and school social workers. I am definitely one I want to give them as much information as the family wants me to give them. I'm not gonna disclose all of this stuff on behalf of the family unless they want me to, but definitely being able there to support them in whatever way is appropriate and whatever way they need us to and want us to.
And if you're cognizant of a child that's in foster care and there's a foster care review board coming up where that child is going to be reviewed, would you either be in attendance or submit a report to that board?
That's definitely possible. I personally have never been asked to do that or done that. I've talked to a couple workers just on the phone and given them updates. Again, I think just on my end, it goes back to what the family wants me to do and how involved they want me to be.
Because I'm coming from this point of view, obviously, that the more information you have about a given situation, the better recommendations a board can make. If it's a foster care review board, or the better educational opportunities for that child to continue to grow and develop if it's within a school situation. I mean, it goes back to it takes a village to raise a child, so to speak. And the more people that are involved with that child that are willing to share, the greater the degree of success, or it increases the degree of success for that child.
Yeah, definitely. And I too, and I know Mary Kate's the same way, we always want to advocate for our clients. We're both social workers, so that advocacy piece is huge for us and wanting to be there for our clients and do what's best for them. So a lot of times we are asked to do things like those IEP meetings or those letters, that kind of stuff. So that's definitely something. I can't obviously speak for all providers and all therapists that you guys may run into, but at the end of the day, I always want to do what's best for my clients.
And as therapists, we're bound by HIPAA. So we can't really get involved unless we're asked to get involved and we have those releases of information. But obviously, absolutely. We also think that, you know, the more holistic the care we can give the client, the better the results are going to be.
Any other thoughts or comments? They don't have to be questions, just comments. Something that really surprised you that we told you guys. Anything?
The thing that's coming to my mind as a CASA, how much should we be talking about when we know there are children that have experienced sexual abuse, but I kind of feel like I shouldn't talk about it unless they talk to me about it.
Yeah, definitely. I mean, that's something, you know, like your supervisor, your whatever the standards are for you guys. But yeah, definitely in your comfort level too, if that's something that's technically, you know, you're able to do, but you don't want to do, like that's okay too. So yeah, I don't know if that's something that I can really answer for you.
I think
so. Maybe check with the supervisor.
Yeah, I would check.
Yeah, Emma and I have both worked at child advocacy centers. And so I think the big thing that comes to mind when we think about talking about child abuse is making sure that we're asking those non-leading questions. I think, I'm not sure what the rules are for you, but obviously for us as therapists, for child advocacy center workers, there's different rules and regulations on what you can say and what you can't say to kiddos. But if a kid goes ahead and discloses to you and wants to talk about things, be open to that. You know, they're telling you, they're trusting you, you know, that's a sign of trust. And so making sure that you keep your reactions maybe neutral, because some of the things that come out of their mouths are a little startling. But making sure that they obviously trust you. So give them that space to talk about what they want to talk about. They're trying to show you who they are and what has happened.
I need a clarification. I need a clarification to that last question. I think it was Teresa's. So is Teresa saying the child is revealing that for the first time, or that was already known?
The child told the therapist, and then it came to me through the information from the therapist. The child doesn't talk about it, but I worry that the child is not going to be protected or be safe when he's back in the home environment, that he doesn't have the skills to stop this information or know who to talk to or whatever.
Okay.
Yeah,
so it's more a worry.
Yeah, definitely a big worry. I think something that could hopefully give you some sense of comfort is knowing that he's engaged in therapy and he has that therapist that if he's already disclosed to, he hopefully trusts and has a good relationship and rapport with. And if he does end up going back to that home, that he would be able to disclose to the therapist if something were to happen again.
Maria and Emma, do you evaluate children for ADD and ADHD and obsessive behaviors too?
Yeah, we can. That is definitely a diagnosis that we consider when appropriate and look at. We don't do any medication management or anything though. So we can diagnose with that, but we can't prescribe.
Is that diagnosis accepted by the AEA and the school district too then?
I don't know about that.
Or do they have to go through their own testing procedure, so to speak?
I don't know if it has to be physician directed or if a therapist can diagnose for like a 504 plan.
I know a lot of times AEA does a lot of their own assessments too. So, because they do it, the assessments and observations in school, which is obviously a little different than, the family coming to our office.
I had a question. What treatments are different or are used when the perpetrator is also a child, like for the perpetrator?
For the perpetrator? That's an awesome question. A lot of the same things can be used a lot of times, not always. A lot of times though, the child perpetrator has been perpetrated on, whether that's by an adult or witness to something like that they shouldn't have seen or stuff like that. A lot of times though, it would be that CBT, DBT trying to identify what led to these behaviors, and understanding thought processes and behaviors, and then helping to reframe them and working through that guilt that might be associated with it, depending on the age of the kid, and working through it like that. So again, a lot of the same things could be used. Any other questions or comments?
Thank you so much, ladies. If there are any questions, are you good with me just sending questions to you, emailing them, and then you'll answer them from there?
Yeah, for sure. That works.
Mary Kate, will you, I don't know if you can email me, so I'll have your email address also.
I'll shoot you an email right after this.
Okay, perfect.
Well,
Okay, so if any of you have any questions, just send them to me, and I will reach out to Emma and Mary Kate and see if we can get answers. Thank you both so much. I mean, this has been very helpful.
good. I'm glad. Thank you guys all.
We will definitely be looking for you for other trainings to help us understand different things in the future. Thank you so much.
Yeah, thank you guys.
Thanks for joining us.
Yeah, have a good night, everyone.
All right, everyone. Have a good night.
Thank you for joining in on today's training. We look forward to having you join us again. Heart & Solutions is proud to provide CE eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.